Good morning again, everyone. Welcome back to Ivey Academy TV. We've become, I would call us reluctant broadcasters here. I'm your very reluctant talk show host, Mark Healy. I'm the executive director of the Ivey Academy. That's the learning and development wing of Ivey Business School in London. Thanks very much for taking time out of your day today. We hope you get some value here. I don't know about all of you, but I've had a lot of conversations this week about the new normal. A lot of people telling me what the new normal will be and won't be, and what the new normal is and isn't. If you're paying attention to the news media, I'm sure you are, you'll have seen data and prognostications that are kind of frankly, all over the place. We're coming back to work this summer. It won't be until fall. Distancing will be in place when we come back. Everyone will be wearing masks. It actually won't be fall. We'll be locked down the rest of the year. Distancing is going to be in place until vaccine is in place around 2022. There'll be antibody tests, and that's a get out of jail free card. There won't be because they're imperfect. There'll be a black market, and so on and so on and so on. So, not a big deal if the data and the prognostications are about, the upcoming, or, maybe we'll see the NFL season. As much as we love that, that's really just entertainment in the end. Different when lives and kids' education, people's livelihoods, business decisions are on the line. So today we're going to try and cut through a lot of that noise and talk to some folks that are very informed and have very informed points of view. We've talked a lot lately about how as a business school, we're not on the front lines of all this. Our guests today literally are on the front lines working directly in healthcare and in COVID modeling. So here's who we've got with us. Dr. Cathy Faulds is a very good friend of Ivey. She was first introduced to us by Professor Dave Barrett here at the school. Dr. Faulds is a palliative care physician at St. Joe's Healthcare Center and a staff and family physician at London Health Sciences Center. She has one of those LinkedIn profiles that has about 7 current active positions, including a member of the Technical Committee of Accreditation Canada, where she's working on primary care accreditation standards. She's one of the most respected family docs in the country. Jon Hantho's with us. Jon is MBA 89 from Ivey, sits on the school's advisory board. He's president and CEO at CBI Health. That's the largest provider of community healthcare services in Canada. CBI operates community and hospital-based rehab services, home care services, and a host of other services. Jon, of course, does a million other things, and he likes to joke that his night job is also chair of Life Labs, not exactly a small job. And we have our own Lauren Cipriano with us today. Lauren's an HBA from 05 from Ivey. She holds a BSc from Western and also a Master of Science and a PhD from Stanford. She's an associate professor in management science. Lauren's research interests include focus on the application of statistics, economics, operations research, and systems analysis to health policy problems. And very germane to today's discussion, Lauren is actually currently running COVID-19 models. As always, I'm going to moderate and direct traffic a bit. We also have Sean Ackling-Grant with us. Sean's going to be our tech lead. More importantly, he'll keep track of the Q&A in the chat and curate some questions that are coming in that way. Sean and I will try to come in once in a while with themes that emerge from everyone listening and engaging. We know we won't get to everyone, and we'll make sure we do a good follow-up for the questions that we don't get to. So Sean, maybe just to you to start, can you talk a bit about how all this is kind of really going to work today, please? Thanks.
Sure. Thanks, Mark, and welcome everyone joining us from home. If you've been coming to our webinars so far, you know that we love to hear from you during the session. So you can send questions to us by clicking the Q&A icon in the bottom of your Zoom window. You can also upvote other questions by clicking the thumbs up icon. So that will bring popular questions to the top, and we'll try to make sure they get answered for you. We also have several hundred people already tuned in, so please feel free to use the chat to share ideas and thoughts with us or one another. Welcome to everyone tuned in as well on the live stream. This full recording will be posted on YouTube afterwards, as well as the Ivey Academy blog. And after the event today, everyone registered will get an emailed link with the video and any slides we use. So again, thank you for joining us, and I'll throw it back to you, Mark.
Okay, thanks. So I think we'll start with a quick poll of the audience just to know who we've got with us. So we may not have the categories kind of perfectly right, but do you spend your time in healthcare? Do you spend your time in government? Do you spend your time in a nonprofit? Do you spend your time in business or somewhere else? Sean, have we got that poll ready to go?
So that poll is launched now and running. Business and healthcare are our clear leaders so far. We'll leave it open for another 10 seconds or so, and then give everyone an idea. Okay, with about 80% of people voted so far. Take a look. And there are the results. So 49% in business, 29% healthcare, government, nonprofit, and some other as well.
Okay, there we go. So let's get going. I want to just talk about kind of where are we right now. So Cathy, maybe we could start with you. Can you talk about sort of your role in the current situation and what you're seeing and how you're feeling about things right now?
Sure, thank you. And thanks very much for the invitation to talk. I'm very much in the thick of things, both from a family physician, where I'm doing virtual care, and I'm limiting my care to essential services that are needed in person. That's why I've got the scrubs on right now. And as well, doing palliative care that you mentioned. So both in the hospital setting and then in the community setting. So I'm going between multiple different sites. So very much living it as a physician. And then I put a hat on, which is a leadership hat for the Southwest region, which is our old Southwest Lynn region. And it's for the non-hospital sector leadership. And I've brought together a steering committee to look at that. I think today we report up to a regional steering committee. I talk with my hands, so I know that's an issue on Zoom. I'll try and keep them down below my face. And then that reports up to the ministry. And so today we got a message that we were in a very good place, that perhaps we are actually through the peak of the pandemic, and that we still have remaining capacity. And so much of the work that I've been doing has been in conjunction with the hospital steering committee as well. And I know that we're below 70% capacity for our ICUs and for our hospital beds, which is really encouraging because a lot of the initial work was put onto that sector. My concern, and I guess what keeps me awake at night, is that the sector I look after, our mental health and addictions, our vulnerable populations, our Aboriginal population, our First Nation Reserve, our community services sector, which has in our Southwest over 200 patients that are vented in the community. We look after a lot of complex, congregated individuals that are frail and that will not do well if COVID enters those institutions. And so I think all of you may appreciate or not appreciate how heterogeneous the non-hospital sector is. And I guess my concern is that my role is making sure we understand that risk and we mitigate the risks that are existing in the sector. And I don't think we have a good handle on that yet. I came on the job not even, well, it's 2 weeks and 3 days ago to try and pull this together. And I think we need at least another 3 or 4 days to get a really strong handle on where our risk is. And I don't want to spend too long, but just to simplify and say that our retirement homes alone, we have staff that are present that aren't all versed on how to do swabs, how to use personal protective device and equipment, how to manage symptoms, how to recognize symptoms in patients that could be COVID positive. And we don't have an on-call system for medical emergencies and crisis management in our usual healthcare system. So no small feat to pull that heterogeneous sector together, make sure there's 24/7 call, and then to implement an education structure and program around keeping staff and residents safe, in addition to knowing when and who to test and how. So maybe I'll stop there and give the others an opportunity.
Yeah, Jon, maybe we can go to you next. I know you and your massive team spend a lot of time thinking about the community as well. Could you just maybe give your view on where you think we are and how you're feeling?
Yeah, sure. First of all, hard act to follow. And to Cathy, who is actually on the front line, thank you for everything that you do. I think it's important to kind of recognize there's a lot of people putting themselves in harm's way, and we shall be grateful for that. We have roughly 13,000 employees across the country. And we feel that all of our businesses, frankly, all our service lines make some level of contribution to the pandemic response. So we have a part of our business that does more complex rehabilitation services, working with the workers' comp insurance companies of the world, with individuals that really need our help. And and we were through clinics, and we had 200 clinics across Canada. And as you can all appreciate, those are not open and functioning except on an emergency basis. And so one of the things we've had to do is pivot our ability to serve these clients. We went from virtually, well, funny word, virtual, but we have gone from almost no virtual care, just really limited virtual care, to now having over 1,000 clinicians, therapists trained on this. We did last week roughly 23,000 online virtual sessions, and 4 weeks ago we did a handful. So quite impressed with the pivot, but the important part is this: our job is to keep people healthy so they don't go into the acute system. So that's that role. The bigger part, and probably more relevant and aligned with Cathy, is we have one of the largest community care, specifically home care businesses across Canada. And so we're in these communities all across Canada. Roughly in Ontario alone, we have 4,000 individuals that are staff and professionals in the communities. And our jobs are to keep people safe and healthy in their homes. And again, it contributes in a major way. What keeps me worried right now is that we've had such great focus in on the response at the acute level that, and now it's shifting very quickly, and we're all in the headlines on long-term care facilities. We don't want to forget about home care. Like, this is important work. And to Cathy's point about, these are the frail, the elderly, people in different levels of medical care, medical requirements that need attention. And right now, it's not getting a ton of press, and maybe that's a good thing, but it's an area that we're concerned about, making sure that we have the right number of people with the right training, with the right PPE, and that dominates our conversations every single morning, and will continue to do so, because what we're waiting for is the wave. So everyone has told us, be ready for the wave, be prepared for it, whether it's Alberta, whether it's Ontario or other provinces. And so we have created enormous capacity to take on the decanting of hospitals. And we're ready for that, but it has yet to arrive. And so we're ready, willing, and able. It's one of those things you hope doesn't arrive, but you're ready to have it arrive.
Okay, thanks, Jon. And Lauren, let's come to you. Same question. What's your role right now? How are you feeling about what you're seeing?
My expertise has been for some time now, the modeling of both infectious and non-infectious disease for the evaluation of public policy and technology assessment. And so I've been putting that to work in this context. I've been working with a team at LHSC in the critical care department to develop a model projecting when we will need certain numbers of beds and what resources we'll need in the hospital space. But to Cathy's point earlier, that really includes understanding what's going on in the community and the number of infections that are in the community, as that's where the demand for critical care is going to come from. And so we've been building a spreadsheet model, like many of the alumni are maybe familiar with from their management science classes, to understand and do some predictions of both short-term demand for our hospitals and long-term. We can use mathematical models to then evaluate different hypothetical policies, to evaluate what the benefits of social distancing is, how intensive our social distancing efforts need to be to really manage the epidemic in the short term. And then as we think about policies forward, how many people in the community would we need to have already recovered, immune through natural processes or immune through vaccination before we would actually be able to return to normal? Or as we saw come up in science last night, policies for pulsing in the community. So what if we were going to lift and do intensive monitoring? How could we estimate how often we would need to do that, how intensive we would need to pulse, and what parts of our economy could we lift up at what times? And so I think that modeling allows us to do a lot of what if scenarios and evaluate what uncertainties are the most important. Right now, the uncertainties that are the most important to me are the number of unknown infections in our community. That really is driving how many cases we're going to need in the hospitals, and how much work Cathy and Jon's teams are going to need to be doing. And so I think that one thing we don't know is what is the prevalence of COVID-19 in our community or in Ontario. And I think that needs to be addressed. And then we've got a number of vulnerable populations. And Cathy and Jon have talked about two groups. I'd raise the homeless, incarcerated individuals as well as potential places where an outbreak would be catastrophic to our healthcare system and our local healthcare resources, also to the individuals involved. Right. So right now we're talking about what does social distancing mean for people who sleep in shelters or sleep on the streets. And if you're able to provide some sort of temporary housing, what does that mean in terms of all of the wraparound supports? And so it's one thing to put somebody in a motel, but motels don't have food supplies. And so how are we dealing with all of the back end social support an individual in that sort of high risk situation needs?
Okay, I mean, already so much to dig into. Lots of questions coming in through the Q&A in the chat too, really in sort of two categories. You know, one of them is about redeployment of resources. I think we'll come back to that point. And then next one is about data and models and curves and shapes. And so, you know, I think here's where we'll go with the rest of this session. We're going to talk a bit about what data we trust, what the data is telling us, and then ultimately where do we sort of go from here. So let's dwell on this point about what data we trust. I know that's one of the questions that floats into the academy all the time is, you know, hey, what are you guys looking at and what do you trust? So instead of, how about the three of you? Lauren, let's just stay with you for a second. What data sources do you trust?
So right now I would, for my sort of popular press sources of data, I'm sticking to the most mainstream and the most well-resourced. So the New York Times, the Washington Post, the Guardian, and here in Canada, the Globe and Mail. And so I think where we can trust our well-resourced, highly experienced reporters who are experienced curators of especially science news, I think that's going to be our best sources of information. And we have to be very wary in the popular press of more fringe or less reliable sources, and being really on alert for sort of misinformation coming from those sources. And then on the scientific side, I think that's a very difficult space for all of us right now, as we are used to relying on peer-reviewed publications. And now even our peer review processes are happening almost too fast for the to know that they're as thorough as they normally are. And so those of us who are relying on the scientific literature are relying heavily on pre-press. And I think that requires us to be more critical of the sampling methods, the potential for bias, the reputations of the scientists involved, their prior experience, and the types of information they're able to provide. And so we need to be very thoughtful about the uncertainty. And I think right now, sort of everything we know is known with a grain of salt and with lots of uncertainty. And being thoughtful about that uncertainty is important in all of our planning.
Jon, you've got big decisions to make, big scale decisions to make, involving lots and lots of people. Who and what are you trusting?
Well, we have to rely on the Ministry of Health. We have to rely on, in Ontario, the LHINs, for example. They are they're faultless in their frequency of communication. I think they're clever about the brevity of it, so it's actionable data for us. But like any, when we speak to also hospital CEOs, for example, we get the same feedback, which is their models are unproven. And so they have models, they share with us when they think things like surge peaks are going to happen, but they will always say, but we just don't know. There's not enough data inside of these models to really have a high degree of certainty to it. So we're kind of working around the edges on that one. And so you're using, I think, crude predicting models, and we're using, therefore, blunt force to make sure that we're ready. And we're ready probably earlier than it is happening. We've created capacity. And I think, Cathy, when was the last time you'd ever said that you had 70% utilization in a hospital? Like, it's just kind of remarkable. And yes, we put up a lot of things like elective surgery, but the reality is, I think the whole sector has done a good job preparing capacity. I have a couple of gripes around how we manage things like PPE, but outside of that, the data we look for is coming out of hospitals or LHINs or the ministries of health in jurisdictions across Canada. And we are finding it as reliable and actionable as we need it to be for our purposes. It works for us.
sorry, Cathy, any different views or sources that you're using?
No.
You're making different decisions in a way, right? More in the moment.
More in the moment decisions, and I'm relying on the same data I think Jon is, that I get fed each morning at my meeting, the command center meetings they're called. The only other thing I would add is that I have a network of international colleagues that have gone through this, have been ahead of me. And in particular in Italy, some of the New England Journal, I agree with you, Lauren, they're not scientific articles, but they are articles that are written by groups of physicians that are going through this. And so I found that particularly helpful because it's the kind of practical, pragmatic things that we have to think about, like make sure you've got enough oxygen, make sure you've got enough body bags. Make sure you have a process about how to remove bodies from the hospital and the home to the funeral home. Have you thought about your funeral home directors and what's going to happen with them? So there's so many things in a pandemic. And I was around during SARS and I was around during 9/11. And so I've been at it for 34 years and have seen lots of smaller episodes of pandemics, I guess, in Ontario, and have been part of them. But I think this is just, when you're talking about numbers and preparing, I'm just getting the same numbers Jon is, and I'm looking and trying to forecast and listen to people like Lauren, who really do this for a living and are the experts.
Let's go to Lauren, I think, before we leave this topic. To the extent that you can share it, what actual data sources are you using to feed your models, and can you talk a bit about the scope of the models?
So certainly the evidence that came out early out of China, the evidence that's come out of South Korea, and the information that came out of Italy, all been important parts of a learned experience. Even information is coming out of New York that is giving us information about the number of people who are going to need hospitalization, the number of people who are going to need ventilators, what happens when people need ventilators, and what the mortality rate is on ventilators, what other sort of critical care resources they're going to need. We're also learning about the fraction of people in the community who are going to experience sort of a rapid onset and sort of high mortality in nursing homes. And I think that infectiousness is something that changes across communities because of the different density and the different norms for interaction. And so I think some of the early data out of China is maybe less predictive of what we might see in a high density but Canadian city like Toronto, but the information we're getting out of New York might be really relevant in that case. In some of our sort of mid-sized communities that have older demographics, the information we're getting out of Lombardy might give us information about what types of distributions we might see in the community and what kind of response we might experience if we lose control of distribution. I think that the models are telling us right now very strongly that social distancing is our only tool in the toolbox right now, and that the level of social distancing we need to be enacting is really quite high. So I would say that the models that I'm building right now would say that if we need more than 50% of the population participating, and we need to be cutting their contacts by 60, 70, 80% of our contacts. And so anybody who's currently trying to grocery shop every week, if you can do every other week, if you're currently doing every other week, if you could do that every third week, those are the types of things that are going to make a difference right now. Because if the peak is right now or already behind us, because we were quite lucky in Southwestern Ontario and we didn't end up with a lot of imported cases and we didn't end up with a lot of community transmission before we started to reduce services, then that's great. But our risk of imported cases and community transmission will continue until we have community immunity. And so I think that so any sort of letting up is going to put us at risk for a resurgence. And so right now, what we know from the models, social distancing works, but that's going to have to be high intensity social distancing like we're doing now. But that social distancing is also giving us time. It's giving us time to answer questions about the natural history of the disease. It's going to give us time to answer questions about the durability of immunity that comes from recovery. It's going to give us time to develop high quality tests for looking at antibodies. Right now, we don't have that technology. It's going to give us a high quality, hopefully, ways of monitoring and doing contact tracing that are going to be more effective than what we're doing right now, which is a very manual human process. And it's going to give us time to develop strategies as both business and public policy makers that might allow us to partially restructure our economy in ways that allow us to interact in ways that continue to be safe from an infectious disease standpoint, but also allow us to function as a cooperative and productive society.
We have a question here in the Q&A, and it's something I wondered about. So the initial guidance was don't wear a mask, then the guidance was wear a mask. Is wearing a mask one of the variables that you've built into your models?
No, I have not been putting mask wearing into the equation right now. I would say that I'm modeling at a much grosser level than that level of detail. And I think right now the most detailed models are including elements of seasonality potentially, but they're not modeling at the level of mask wearing. I think that the evidence on masks, I think, was partially a little bit confusing. We haven't done a good job of evaluating masks as a way of sort of the general population preventing disease transmission in terms of influenza or the common cold before. And we had a supply shortage. And we want to make sure that masks are available for frontline workers in hospital settings and in home care. And so I think that the communication on masks was probably not very well managed. Because I think it's obvious that that somebody who's unwell wearing a mask is going to be less likely to cough on somebody else. But I think that there's the other issue is who needs masks in our society first, and that's going to be the same question we need to answer when we first get a vaccine. Who needs the vaccine first? It's not going to be me who can primarily do my work from home. It's going to be Cathy who can't. And so I think that when we think about allocating masks or allocating vaccine and allocating other resources, we're going to need to be systematic in how we approach that. And so I think that there's also an argument around a mask making you feel safer than you should be. And so step one should be try not to leave your home unless absolutely necessary. Step two is, if you have to leave your home, a mask might make you a little bit safer.
Yeah, I agree, Lauren. I think the whole question of masking is really about the cadence of how the disease has come in as well. And so making sure that we understand IPAC guidelines and we're able to put those IPAC guidelines in based on where the disease is and where it isn't is really important. And so I hear that from everybody. Cathy, you told me I didn't need a mask 2 weeks ago, and now you're telling me I do. And it's really about the cadence of the disease entering our community. And so the N95, it's understanding who's doing the highest risk procedures, where those may be. Those are in hospitals, they're in the emergency department, they're in the ICUs, and those particular people need N95 masks, and they need full donning, and they need to know how to don and doff. The problem or the gap is that we do a lot of respiratory procedures in the community, and there is a lack of understanding, and John's shaking his head because he gets it. I have 200 vented patients in the community, and everybody who enters those homes and is dealing with those patients needs N95 masks, and they need to don and doff. Because we really don't know in those situations what might be transmitted. And the whole issue of asymptomatic carriers of disease has come up. And is there a viral load that's important? And I've said to people, if you're within 6 feet of someone and you're doing care right now in the community, you should have a surgical mask on. And our committee this morning, our non-hospital sector committee, because the Ministry of Health has put a directive in place for all long-term care employees and staff, and for all retirement employees and staff, but have not issued directives for everyone else in the community. So someone who's working in our local shelter in London, Middlesex, I have said, you know, if you're getting within 6 feet of someone and there's a potential that you're going to get a viral load, then you need to wear a surgical mask. And the issue about supply, to me, although it needs to be taken into account with the best medical evidence, I think we need to protect the people that are doing the care, and we need to protect the patients. And a surgical mask for you out in the grocery store protects only me from you. It doesn't protect you from me. And I know that sounds like a silly thing, but I think that's what Lauren was trying to get at. Cloth masks, I get asked about that 100 times a day. Anything over your face is better than nothing. We talk about something called N95, and that's how much is kept out. So if you think very simply that 95% of everything's kept out, if you put an N95 mask on, a surgical mask, depending upon who you talk with and the level of the mask that's made, could be anywhere between 55 to 85%. A cloth mask, depending upon which research article you look at or who you listen to on Twitter, could be anything from 3% to 30%. So my point to people is just simply know your own risk in what you're doing, mask accordingly to IPAC guideline. And at this point in time, all of our workers that are within 6 feet of someone should have at least a surgical mask on. The problem of supply, John, I don't know if you're going to get into that, but it's we in the Southwest set up hubs, and because we are very, very fortunate to have businesses in town and across the Southwest who have been incredibly generous. I joked with somebody and said the only reason why we have masks in our London hub is because we've got a lot of really dedicated business people that have opened their checkbooks and been able to order and fill it. So we have hubs in our region that are filled with donations, and we still have donations. And then we have the provincial supply that's coming down through what's called our HMMS system into those hubs. And then we have an emergency supply as well that's being kept back by the Ministry of Health. There's lots of reasons behind how this has worked and the distribution of PPE and the availability of PPE. There's transparency in terms of dashboards now that are out in many parts of the province. And I know our dashboard for PPE is transparent. We aren't shy of PPE currently at this point in time outside of some disposable gowns in our community. But we are looking at every which way to recycle PPE. And so that's going on in the background as well, because again, I said to people, I don't know if I'm preparing dinner for 10, dinner for 2, or dinner for 800. And so I choose to be prepared for all 3 of those. And I said to someone, right now it's looking like we prepared dinner for 10 and only 2 have come. What a great problem. We have extra food in our fridge, we have capacity, and I'm okay with that. You can be critical of me long term, and I'm okay with that. But if I prepare dinner for 10 and you invite 800, we're in trouble. So that's where the recycling of PPE and the perhaps, I'm going to say hesitancy in my voice to be incredibly optimistic is here today. I'll stop there. John, you've probably got lots on PPE.
Well, I'm not going to say too much on PPE because it's, a month ago, no one knew what PPE was. Now we all talk about it like we know what we're talking about. So here we go. So we have a different reality. So home care is, by the way, home care as an industry is both a mixture of nonprofit, for-profit, and we all do effectively the same things, and we do it with passion and commitment and purpose. But we're also, I think, really much forgotten. And so in the scheme of the focus on preparedness, on acute care, and shifting it from acute care to long-term care, the reality is home care is left by and large on its own. We do not have access to provincial inventories on PPE, with a couple of notable exceptions, most recently in Alberta in the last 2 days, kind of opening it up for home care. We have spent as an organization we've probably spent more, I know we have, in the last 3 weeks on PPE than we have all of last year. And it's not because our volumes are up so much, but because we're paying between 9 and 15 times more per unit. And we don't have access to the other stockpiles. And this is, whether you're non-for-profit or for-profit, we are all in this together on this one. So we are, without a doubt, waving the flag high in the air saying, be careful here. What could happen is the unintended consequence of really protecting the acute care system is that when you need us most in in home care, when people are decanting from hospitals into the communities, we may not have enough PPE for our employees to be safe to go into those homes, and they could either refuse, which they are already, or we put them at unnecessary risk, which is just not acceptable. So we need to see, and we continue to advocate for a more holistic approach to the managing of PPEs and the distribution of these things. And we just want to make sure that we have that access. And we're looking at a number of different strategies to do it, even at a federal level. We'll see how that all pans out. But for now, we're on our own to kind of make sure that we have the right supplies.
Yeah, and I think you're bringing up something that is a really important, I would say, business aspect of this, but more so ethical. When you look at the emergency supply for PPE from the Ministry of Health, the mandate last night was, Cathy, it can come to hospitals, it can come to long-term care and retirement homes, period.
Right.
I have advocated for different than that, because you're correct, the home care industry is left out, the primary care industry is left out, Aboriginal health is left out. And so my mantra in the Southwest has been nobody's left behind. And that's why I've fought so hard for donated items. But again, how sustainable is that in a pandemic? The emergency response supply, the 30%, is accessible to the home care industry, to primary care, to our Aboriginal and municipal in EMS. EMS is also not in that ministry HMMS supply. So I totally agree with you. It's one of I think one of the things that's happened is that as we were beginning to get our OHT work and our transformation to say we need to integrate our hospital and our community sector, and we need to flip the triangle from the emphasis on the acute care system to that onto the primary care foundation, a pandemic came along. And so we're just witnessing the gaps and the difficulties that we have in our regular healthcare system. And if we're not careful, it's going to really be an issue, because we have not put enough into our community and our healthcare system in primary care. Right. And, you know, I say this over and over and over again to people, that 25% of your wellness, whether you live or die, depends on the healthcare system. Only 25%. The remainder is the community and your self-management. So your self-isolation that Lauren is just absolutely, you know, hammering for us. So thank you so much. And that 25% has the wrong emphasis in our system. And I'll go on every stage that you want to put me on and say that over and over again. And that's not to belittle, that's not to negate, that's not to say that I'm not incredibly proud of our hospital system and the work that it's done in preparation for this pandemic. I have honestly never seen our system work so well and so coordinated. From a hospital and an emergency response.
We would share that observation, Cathy. The conversations that we are having with hospitals on creative strategies to move people out of the hospital quickly back into their homes, but still get access to therapeutic care. Yeah. To your point, the Ontario health team, this is that process on steroids, because you never want a good crisis to go to waste, and at the same time, we are seeing enormous innovation. And so I think there's some real benefits that are going to last way beyond the pandemic for the system on just how agile and creative we've actually been together. So I agree with you.
I want to get to, what changes are going to be lasting and which ones aren't, and nothing's going to be perfect on that. But just before we leave this pasture, just one more word, maybe Jon, from you. We got a lot of business folks tuned in today, probably running scenarios like I am. I'm sure you are too. You've got a business side to what you do, not just the healthcare side. Any sort of advice on your read of the data for business leaders and decision makers?
Yeah, this is a tough one, right? Because I'll defer to Lauren on I think she's better read and knowledgeable on some of the modeling, but the notion that we're going to come out of this and we're just going to go back to normal, even by the fall, I think is ridiculous. It's just not going to happen that way. The reason why we're doing so well is because we're doing such extreme measures on social physical distancing and all the things we've talked about today. So we're going to live with this virus, I think, for years, in a personal opinion on this one, and that we are going to there are going to be hot spots over time. It's going to flare up. We're going to have to become an incredibly well-tuned, community, business, health authorities, all the above. We're going to be really well-tuned on how to adapt to this new reality of bringing people back and getting the economy started up again, and realizing that it's imperfect and that we are going to have outbreaks and that we're going to know how to respond to those, and we're going to know how to do it. It's like a fire drill. We're going to be really well-tuned on how to do this, and it's going to be new methods, I think new muscle power for us. But I feel strongly that the new normal isn't going to be the old normal, but it's going to be some hybrid of this, and we're just going to have to be remarkably agile as communities, as businesses, on how to adapt to this. And so I think this notion of social distancing, physical distancing, it's here with us for a while. Until we can take care of those vulnerable populations on a mass basis, we're going to be into this for a while. And so even from our own business, we're entirely virtual now. Like it's actually quite remarkable, except of course, our frontline workers that are with our clients and patients and individuals every day. And so I don't have great words of wisdom on this one, other than there is no back to normal anytime soon. I just don't see it happening.
Yeah, it's funny. We had Tony Frost, a professor, here on with us a couple of times in the last 2 weeks, talking about, from a sort of economist point of view, about business is one of the hardest things, especially for large organizations, is to do exactly what you talked about, which is to turn on and then turn off and then turn back on again. We're good at this sort of linear, not so good at on off. So something clearly to think about. But let's shift back to the health system here broadly, and let's move into our last kind of territory, and that's kind of where do we go from here. So one of the things I want to get to, and maybe Lauren, we could start with you, is what will we have learned through this, and what should we have learned through all of this?
So I think that right now the modeling work is also telling us what are the most important uncertainties that we need to answer before we can make any sort of real sort of substantive moves on our policy change. So one of those things that we don't know right now is how many people are infected in the community. And part of the challenge in even identifying that isn't just, do we have enough tests and can we prioritize tests to answer that question, but is also the quality of the tests. And so we know that the tests we're using to identify whether or not people are infected have a 70 or 80% sensitivity. That means that if a person has the disease, the probability that they're going to test positive is only 70 to 80%. And that requires them to have symptoms. The more symptoms somebody has, the easier it is for the test to find the virus so that it can detect them as positive. That means that the less symptomatic people in the community or potentially subclinical cases are going to be the hardest for us to find when we are able to implement that. But that's going to be the uncertainty that puts all of our most vulnerable communities at risk, and sort of puts the things that we do as normal parts of life that have the most mixing, like our educational institutions, at highest risk of sort of continuing with sort of normal operations. And so we need to be able to identify what our prevalence is in the community. And that's not just of people who have recovered using a sort of serology testing, looking for people who have antibodies, but looking for active virus in the community. I think that in the long run, it's going to be harder for us to imagine what travel means. So if you can imagine that in your community, you have a strong sense potentially with enough good data collection of what the virus is doing in your community, that's going to allow us to start to restart even normal healthcare operations in our hospitals. If we're running at 70% capacity in our hospitals, we know that's because people are foregoing healthcare that they need potentially. That's elective surgeries that are not happening. And so even just knowing what's going on in our community is going to allow us to step back into making sure that everybody gets the other types of care that they need in our community. The last things that are going to come back are our ability to travel regionally and travel internationally, because right now it looks like we seem to have this under control, at least here in our very local region, but it is not very far away that they don't. And so as soon as we start imagining taking the train to Toronto and back in, that probably all of us have done within the last 6 months, that even that type of travel is going to be much more restricted. And the idea that we'll have normal international travel back in 6 months or a year is hard for me to imagine. I think the first thing that the models told me that was different than I was reading in the press was the amount of endurance. And I think that's come out in the popular press more recently, that this is going to be an endurance game. And I think it's a different thing for a business to plan for 2 or 3 or 4 weeks of shutdown than it is to plan a totally reinvention of your business model, because it's going to be 6, 8, or 10 months before you're going to be able to return to a normal business model. And so what is a change of total strategy happening on a long horizon? This is an endurance game.
Let's go there. Jon, is virtual care here to stay?
Oh yeah, and you know what? It's actually quite remarkable. It is the conversations that we are already having after only 4 weeks of this is that this has fundamentally changed us. Like it just has. The service delivery, you know, we have to be responsible for clinical efficacy. Like we have to prove the outcomes that we, you know, promising to our clients in the physical, they'll call it in-clinic models, and we're actually doing that. And so I think the body of evidence is going to support that we can actually do both. And so I think the future of our business isn't going to be an on-off switch hybrid model. I actually think it's going to be much more integrated, because we're actually getting we're getting more comfortable delivering this therapy, but we're supporting it. And I'll give you a good example right now. We have this really neat unit called Monarch House, which works with families with autistic children. And they've been completely shut out because of this, the COVID pandemic, because they can't physically come to us anymore. The work that we are doing on virtual care is a lifesaver. And now we're realizing, you know what? We don't necessarily always have to have them come in for some of the therapy that we can do. We can actually support it with virtual therapy and accommodate different schedules and different geographies. So it is fundamentally changed the business, and our funders and our partners are seeing its value. And we're going to continue to prove out the clinical efficacy of it, but it's different. It's a game changer.
Cathy, what's going to have changed through all this permanently?
I think the relationship between public health and the healthcare system has to change. I think there's been many barriers to how both are set up, and I hope this is going to be digested and dissected when all of this is over, or even as we go along to make those changes. Lauren and I have talked a little about that. Virtual care and primary care. Kaiser Permanente has a great model for virtual care. About 50% is done in primary care. This has just turned a switch on for that, both in mental health and addictions, as you've mentioned, Jon, in home and community care, but also in primary care. The integrations and transitions between our system, I would say we have just broken those down in the Southwest. So how do we take someone from the community that needs to go to emerge and back into the community rather than be admitted? How do we direct admit into hospitals, something that I used to do 25 years ago? Everything old's new again. How do we discharge plan people from the hospital to home? And how do we rapidly respond to people in the community? I know it will shock people to know that we don't have 24/7 on-call for the patients that Jon looks after in the community. We don't have an on-call primary care system. We do palliative care in the Southwest, but not primary. And we're changing that. We're trying to put that in place and make sure that people have a 24/7 response, and 24/7 response, not only for paramedicine, but for primary care, palliative care, and for nursing care. And then we're also talking about how do we support caregiver burnout. So kind of 3 levels of crisis response. And caregiver burnout, our traditional way of waiting for 2 weeks for a respite bed is just not going to cut it during a pandemic, and it shouldn't cut it in our regular healthcare system. So there are many. I was thinking I have a whole list down I could list, but you know, there's a lot of things that we're putting in place that I love having the ability to say, you know what, guys, we're in a pandemic. You don't have 5 days to give me that directive back. I need it tomorrow in 24 hours. And you all need to get along. You need to work on it. And it needs to be back on my desk so that we can go the next step of the project. there's something to be said about a pandemic changing how we do business. And I think there's a lot of good things that are going to happen. I'm going to be happy to give up the long days. I'm going to be happy to give up the lack of time maybe to think about the modeling work. One of the things that I've learned as a leader, even more so, is know my lane really, really well, and then make sure that to people like Lauren, to people like Jon, I don't have Jon on my committee. I would love him there, but I have someone else from the SPO sector. I just go to them and say, what should happen here? So new leadership styles in healthcare, I think, are really coming to the surface as well. And they're more collaborative, and it's more leading from the back of the pack as well. And a little bit more command leadership, knowing when to follow. I'm seeing that as being really critical.
Well, that's great. At least there's sounds like there's a bit of upside here. Hard to see it sometimes in a crisis. Yeah. Even in our business conversations, we've heard grains of opportunity, grains of innovation, and it sounds like all three of you see some upside in terms of forcing change in the health system here, which is good.
Mark, can I comment on something though, just to add something to this, because those are really good lessons learned. That same, one of the questions that was asked earlier on one of the, on the Zoom window here was really, how do we feel about the response? And I think what Cathy and I probably are uniformly in agreement on is it's actually been really quite extraordinary, and we're quite proud of the response. It's done things, it's created whole new pathways to solutions that are really quite extraordinary and with speed and intelligence. We need to take that same energy though, right now. Like, it's great to hear the government talk about recovery and that they're working on it. Well, I don't want them just to be working on it. I want us to be working on it together. So we need that same energy, that same enthusiasm, the same intelligence with the healthcare professionals, but also bond onto that government and also business. And by business, I mean large and small businesses. We don't want to forget a lot of the engine of our economy is small businesses, but make sure that they have representatives. But I think we need to be intentional about our recovery. I think we need to have the same kind of conversations we have about preparedness and the execution of readiness on a pandemic at a healthcare and a health crisis. But we need to apply that, I think, on the business side with that same rigor, the same planning, so that it's intentional. If we don't get too intentional, we're going to wing it, and we're going to find ourselves right back here having the same conversation. So I think we should take the energy and learning that we've done in the healthcare sector over these last, it's not 4 weeks, it's actually closer to 12 weeks in terms of the work that's been done, and apply that to kind of how we want to jumpstart the economy.
That's fantastic. For once, we've actually covered the ground that we wanted to cover, and we're not a minute over. We've got a little bit of time. So if you guys are cool with it, I actually want to do a few rapid fire questions that have come from the Q&A. Is that okay? Okay, so Lauren, the first one's going to go to you. I'm going to paraphrase a little bit. It's from Michael Baines, he's basically asking about different geographies, and do you imagine that there are kind of different rules, for different geographies, and/or we're opening things up at different paces and different speeds depending on the region that we're talking about in Canada?
Oh, definitely. I don't think that the entire country is not going to open all at once and then shut down all at once. I think, again, and because they will be lifting slowly, I think that each community is going to have to make its own decisions about what that looks like in its community, and it's going to need to be because they have addressed the people most at risk in that community. And so it will be that a city is able to open when the sort of the people most at risk in our long-term care, in our home care, are homeless in shelters and on the street, when those people have an ability to socially distance and have appropriate care and monitoring and the equipment to safely be cared for in their homes, that's going to be when an individual city can start thinking about doing things like restarting elementary schools and the children that need to be in classrooms the most, being in classrooms of potentially, say, half the class size, so that we can implement as much social distancing as we can in classrooms. So it'll be a slow, deliberate process that communities regain, but it won't be until a community has dealt with the most acute forms of risk, because we are and Cathy has said this, I think, earlier in this call, that, you know, we're one nursing home or one shelter away from wiping out all of the beds that have been set aside in critical care units and in the hospitals for COVID patients. And so the risk of a super spread event has certainly been demonstrated in Italy and in South Korea as being the trigger that can very quickly wipe out a community. And it is when we run out of equipment in our hospitals, whether that's physical equipment or human resources, that very quickly the mortality rates from this disease go through the roof. Because if there's not a ventilator when you need a ventilator, people die very quickly. And so that's always going to be a regional issue, where it's not going to be that we can very quickly access ventilators that are in a different province when we need them. And so I think that it's going to be local regions that are making those decisions. And the medical literature tells us what allows people to maintain quarantine for longer periods of times. We've seen wide ranges of quarantine response in response to Ebola and SARS and other H1N1 in the past. And what allows people to follow quarantine instructions and adhere for the full duration is really about understanding what they're facing, understanding the risks, and the feasibility and the practical issues in their everyday life. We need to be able to identify solutions to make this practical for families who are struggling with sort of practical issues of everyday life, like groceries and childcare, and trying to educate their kids while trying to work from home. And so until we can also address sort of these not healthcare issues, but the practical issues of physical distancing, we're not going to have a robust response on the prevention side.
Okay, thanks. Sean's got the next one, I think.
Yeah, I'm seeing a few questions coming out of the chat asking about how Canada stacks up to other countries, or at least how we can look to other countries for maybe models of what's worked and how we can look at reopening. Maybe I'll pose this question to Cathy. How does Canada stack up, and where should we be looking to draw lessons from around the world?
Yeah, I think we currently stack up really well. In terms of numbers of cases, in terms of deaths. So we're certainly very low on that curve. We haven't started, there's some thought that we've started to flatten in the last couple of days, and so we're doing really well with our social distancing. So I think right now we're stacking up really well. And I would just say we have to keep it going. We have to keep it going. And I think Lauren's message that she just gave was beautiful about how we can't let up, because until our most vulnerable in our population are cared for and we know and understand the risk, we're all at risk.
Let's do one more. Lots of questions. The get out of jail free card question. Lots of questions about antibody tests and immunity certificates. And is there any validity to this stuff that we're reading about? John, can we start with you?
Oh, you know what? I'm going to pass right over to Cathy. I'm not going to take the physician role at all.
No, and I don't. I think John, and I think it's too soon. And I think people want a quick fix and a quick answer. And I think just frankly, it's too soon. I was thinking as you were talking about travel, and I was thinking about, one of my young daughters, I'll put a plug for Ivey. She's an Ivey grad. And she said to me, Mom, we need to make sure, and it's going to happen, that we all have passports, and that until we can go someplace, our passport's going to be scanned and looked at, and where did we travel and how recently have we traveled? I can see that happening. And I went, no, you're crazy. That's a bit too big brother for me. And she said, well, think about it. Are you still taking your shoes off at the airport after 9/11? It's going to change how we are, right? It's going to change how we are. And so I don't think we really understand how it's going to change, but I think antibody testing is too soon. There's no get out of jail free card here yet.
I don't think that there's any reason to believe that we have right now a large amount of immunity in the community yet. I think that that remains a medical question to be answered. And I know that there's studies here at Western and in many other places to evaluate how much immunity might be in a community. But I don't think that there's a lot of hope that it's a very high number right now. in the long run, antibody tests might be a part of a functional solution, but we also haven't seen very strong validation evidence coming out of any of the technologies that are sort of being touted in the media right now. We need tests that are going to be highly sensitive, that's able to detect somebody who has antibodies, but also when you're talking about a screening test, you need something that's also highly specific, that's not going to give you false positives. And if people are going to get a pass to sort of rejoin unlimited access to the economy, if they test positive for having antibodies, we can't have all those positives be false positives, because those people will be at risk in our community. And so the quality of tests that we need needs to be quite good. And the tests that are sort of currently sort of circulating in the popular press don't have the validation evidence yet.
Right.
We're up against it on time as usual, so we're right at time. Sean, just a quick final word from you on sort of logistics follow-up from here. What happens from here?
Sure. So we'll be saving all of the questions we didn't get to. Thank you everyone for submitting them. Some really smart questions in there. We'll follow up with our panelists offline and maybe see if we can't get some of them answered individually, either on Twitter or with some follow-up in the blog article that I mentioned. So keep an eye out for a follow-up email from us. We'll send a link to the full recorded broadcast. You can share it, as well as a blog article, so you can get some of those questions answered. Great. So huge thank you to all of you. Like just the fact that you even dedicated an hour plus all the prep time to this in the middle. Huge testament to all of you, Cathy and Jon and Lauren. Thank you very much, and thanks to everyone in the audience that signed on. We will see you next time, which hopefully is tomorrow. Cheers.
Be safe, Cathy.
Bye-bye.
I know.
Thanks very much.